Muy buenas tardes a todos. Gracias por sumarse al último webinar de Medtronic Columna del 2020, un año bastante particular. Nunca pensamos que íbamos a tener tantos Zooms, tantos webinars este año. La doctora Kariman está terminando de loguearse, pero le voy a pasar el micrófono a uno de los oradores, el doctor Luis Eduardo Muñoz de Arroya. Él es del Hospital Pequeño Príncipe de Curitiba, para que, ahí entró la doctora Kariman, para que él haga las presentaciones y dé la introducción al curso. Good afternoon. Yeah. How are you?
I'm fine. Sorry, we had a meeting about COVID, you know, again. So I left too late from the hospital. Really sorry.
Oh, you're fine. You're fine. Just in time. We're just saying hello.
Wonderful.
So I was introducing you guys, and I let you with your friend, Dr. Luis. Go ahead, Dr. Luis.
Okay.
Kari, first of all, I'd like to thank you for participating of this event. I think it's going to be a great opportunity to tell and orientate people here in Latin America. At first, I would like to present you to the guys who already know. There is no need, but I mean, not so many have been, they know what your job you've been doing during this period of time. And the proposal for today is for you to show us how to optimize the 3D correction for AIS using the new Sagital classification. Kariman Abelin Genevois is from Lyon. She does have a very large curriculum. She is now staff senior at Pediatric Spine and CP and responsible for the scientific program at the Medical Center of Le Massue, Lyon, since 2015. She graduated in Lyon. She went through a general surgery and orthopedics in Paris, did a 4-year fellowship in 4 different hospitals. And after that, she did her PhD, 3 years in spine biomechanics at Toulouse University, mainly in AIS and degenerative lumbar spine. Kariman, thanks for sharing your knowledge with us, and sorry for robbing you from your children and your husband. It's a pleasure to have you here.
Thank you so much for inviting me. I'm very honored, and thank you, Luis, for this introduction. So I'm going to share my screen, and I'm going to talk about this classification and how I use it every day to optimize the correction for my patients. Do you see my screen?
Yes.
Yes.
Good. First of all, the talk is about how to optimize 3D correction in pediatric deformity, but I decided to focus my talk on adolescent idiopathic scoliosis because most of my work to optimize it was done for this very special deformity because it's complicated deformity. It's much more easier to speak about deformity that is in one plane, like Kariman, kyphosis, or flat back. But when you enter in scoliosis, you enter a different world where you have to take into account all the different components of the deformity. I don't know why it doesn't work. Yeah. So the goals of adolescent idiopathic scoliosis are to improve the trunk osmosis first. But for us surgeons, we know that what we want for our patients is to limit the functional impact. So we want to fuse at least levels as possible. We want to prevent early degenerative changes, and we know that there are some things to know about how the spine is going to react, especially in the lumbar spine, and we have to normalize the spinal alignment as much as possible. It is quite easy to understand in the frontal plane, and even the patients can follow our explanations about where we have to end with our correction in the frontal plane. We want to be as straight as possible, and especially we want it to be in a good situation in the lumbar and in the cervical spine, have shoulders leveled and have a well-balanced trunk. But the problem is the sagittal plane deformity, because most of the time we have patients that have a disturbed sagittal plane, and we have to know how to bend the rod and how to correct our patients in order to make them happy with the shape, but also to make them happy with what is going to happen in the future. Lenki has done a classification that is worldwide used. I think it's the same for you. This classification was meant to decide on which areas to fuse, which areas to correct in the spine. And you know that there were some modifiers in this classification that were meant to talk about the sagittal plane. First of all, the thoracic sagittal profile. We know that Lenki has decided to use T5, T12 levels to decide on if a spine is hypokyphotic, normokyphotic, or hyperkyphotic, with these cutoffs that are close to normal population, but scoliosis is not normality, so this is questionable. And second, we also have some other modifiers like the proximal thoracic curve with T2, T5 kyphosis, proximal thoracic hyperkyphosis, which means that these patients have an upper kyphosis, but we don't know about what happens lower in the spine. So the big question is, if we have this classification for AIS in the frontal plane and some modifiers, could we do better and have more information about the sagittal plane? Here's the plan I'm going to follow. First, we're going to talk a little bit about the consequences of scoliosis deformity on the sagittal plane. Second, we are going to have a look to what happens if we don't address sagittal alignment properly. Third, we are going to look at this classification and see what kind of sagittal patterns AIS is going to produce. And depending on what it produces, we will define the targets of correction and the possible strategies. This will lead some place for discussion of pre-operative simulation, because this is now offered to decide how we are going to correct the patient before surgery, have a plan and follow the plan. And then we'll have a couple of cases to discuss together. So what are the consequences of scoliosis deformity on the sagittal plane? AIS is a complex three-dimensional deformity. We know that we have an intervertebral extension. This is the first movement for me, but some people are not really agreeing this, but we have more and more proofs of that. Then we have a transverse rotation, because the patient cannot stand with a hyperextension, so he has to stabilize his spine. And at the end, this will produce the classical inclination that we see on the radiograph, and that usually is defined as the Cobb angle. So for me, the definition given by Somerville is really crucial. Scoliosis is a rotational lordosis. So if we want to correct it, we have to correct lordosis. We have to recreate kyphosis in the thoracic spine. And second, we have to give this movement of rotation. But we will see that these two movements sometimes don't go together, and there are some mistakes we shouldn't do. Here, the paper of Peter Newton showing that when you addition all the intervertebral extensions, gradually you create a true hyperlordosis in the thoracic spine here, but you can see it also in thoracolumbar curves. So really this hyper extension between the vertebrae is something that we find in most of our AIS patients. If we look at patients who have severe scoliosis, where it is obvious, and patients with mild scoliosis, we can also find this kind of problems. We did a radiographic comparison between 3 hospitals, our hospital, Utrecht, and Dupont-de-Nemours Hospital in Wilmington. And we compared patients who had either a mild scoliosis, 10 to 20 degrees, that were followed up, and severe patients with more than 45 degrees, either treated with a brace or who were going for surgery. Sorry, and we also looked at normal children from a cohort from Utrecht. And what we found is, you see in green the control, the normal patients. In yellow, you have the mild scoliosis, and in orange, you have the severe scoliosis. We see that pathological patterns, meaning the different types of deformities that we see in the sagittal plane, were very comparable in the groups of mild and severe scoliosis, meaning that this sagittal deformity is there very early and is not depending on the importance of rotation, because a lot of people say that it's only a view of the sagittal plane, that we addition rotation and we have a false hypokyphosis, but it's a real problem that we have to manage. If we see also the epidemiology of sagittal patterns depending on Lenki classification, we can see that thoracic scoliosis, Lenki 1, have almost half of the cohort with abnormal sagittal alignments, while in Lenki 5C, most of the time, we have a shape that is close to normal patients. And in patients with double curves, like Lenki 6C, we have also flat backs that are seen in these patients. So what we saw is that 55% of mild thoracic curves have abnormal sagittal profile. And if we look at other publications that were done on this sagittal profile, we have this study that was done by the SRS 3D study group. And they observed that if we look only to thoracic scoliosis, they could find 3 to 4 clusters: patients with normal kyphosis but hyperlordosis, patients with hypokyphosis, either with normal or with hyperlordosis, and another group with hyperkyphosis. So here you see the beginning of a classification of different patterns. But again, this paper was done only on thoracic scoliosis, so we wanted to go a little bit further. So if we resume, we have scoliosis that is acting on both planes, sagittal and frontal, with a transverse rotation. And what it is produced at the apex is also responsible for the flattening of the spine here. So you have a structural deformity that is both in the frontal plane, we are used to see this and to give a Lenki type, but also in the sagittal profile. So we have to add another kind of classification, and the modifiers given by Lenki are not used enough to help us to guide the correction, and that's why we entered in the description of this classification. Moreover, there is a strong correlation existing between regional adjacent segments. We know that what happens in the thoracic spine will have an impact on the lumbar lordosis, especially on the thoracolumbar junction, and will have an impact on the cervical spine. And the same if you have a lumbar scoliosis and you have, for instance, hyperlordosis, automatically it will have an impact on the thoracic kyphosis. It will have an impact on the anteversion of the pelvis. So this is very reciprocal, and this will explain why when the deformity occurs in one level, automatically there will be consequences above or under this area. So what happens when sagittal alignment is not addressed? First of all, the first main problem that everybody is talking about is that we don't give the proper shape and the patient tries to escape from it. Here you have what I classified as a lanky 4C. Maybe you could say it's a lanky 2C. This patient has, for me, a triple curve. And this triple curve is related to, in the sagittal plane, kyphosis that is quite high. Here, kyphosis is about 56 degrees. For a patient who has a small pelvic incidence, it means that this patient was not meant to have such a shaped spine, but that scoliosis has produced something in the sagittal plane that has these consequences of readaptation. This patient had to be operated on because the curve was progressing and he was painful. For the frontal plane, we decided to fuse the structural curves. So here, if we have a triple curve, we will address the 3 curves. And if you decided it was a 2C, you will probably end at least at L3. So we know the levels we are going to fuse, but the question is how we are going to bend the rod. Are we going to maintain the shape like this? Are we going to change something in the shape? How can we manage the fact that this patient has too much kyphosis for a small pelvic incidence? This is a big question. So here's the surgery that has been done for these patients a couple of years ago. Interestingly, this picture has been done while the patient was seated because he was too painful to stand up the first time. So he was discharged from hospital just with this picture. So here you see the 3 structural curves were fused. It was a T3L3 fusion. At the time we were doing these hybrid constructs. We applied the Lenke rules, and in the sagittal plane, you see that we considered the upper thoracic kyphosis to be too much, and we corrected a little bit of the upper thoracic area. And we changed a little bit the shape of the spine, but you see also that we shaped a lot the lumbar spine, which for me today would be an error, but that's how we constructed this in these patients. So the rod contouring intraoperatively created a true S-shaped spine. We had a patient with a kyphosis that was maintained about 53 degrees, but we reduced a little bit what was happening at the top. If we look a little bit later, this patient has developed gradually pain on the top of the construct, and within a few months, he came back with cervical and low back pain, and this first X-ray showing the standing situation shows that he collapsed at the top. So it's a true PGF with even problems on the anchors here. The reason why the patient required a revision. So this is the kind of problem that we face to know, we don't know exactly where we're going for the correction. And at the end, it's the complication that will tell us if the patient is going to adapt or not to the situation. So if we reanalyze this patient, we can see that patient has a low PI. He has an anteverted pelvis, meaning that if you look at the pelvic version, you see that it's very close to 0. This sacral slope of 38 degrees means that the patient is in Roussouly type 3. So he is creating this lordosis, quite sharp, but he's going too far. We have on the software the levels of lordosis, meaning all the vertebrae that are lordotic, and then we change the color when we have the inflection point where the curve is transitioning. So you see this proximal thoracic hyperkyphosis, and we see that the problem was that the lordosis was too long in this patient. So what should have been done is that we should have corrected the thoracic kyphosis here, but we needed to reshape this area as a thoracic kyphosis to reduce the fact that the patient needed to flex at the top. So here we did a revision surgery on this patient with a new fixation. And you see that the result is not too bad, except that the cervical hyperlordosis was more structural now, and he still has some pain, but he's much more happy. So how did we do that? We did Smith-Peterson osteotomies to do a reverse correction to open the spaces here. And we gave lordosis only on the lumbar area in order to redistribute here the kyphosis and to have a smooth kyphosis that is just distributed until T12 L1 and to have a more adapted pelvic shape. And you see here the values for this patient where we have kyphosis that is still too high for him, but due to this hyperlordosis. So this is a true problem. These PGK cases are not just case reports. We had a look to patients with Lenke 1 and Lenke 2 scoliosis. And we noticed that on these 365 patients, we had 15% of true PGK, angular PGK. Thanks to God, only 10 patients required a revision surgery like this boy. But this is a true problem. And these patients had a minimum follow-up of 2 years. So probably within 5 or 10 years, we would have gone into more revision surgeries. And this is a true problem that we have to correct. The risk factors for PGK in scoliosis were larger pelvic incidences, patients with large lumbar lordosis, because the more you need to create and the more it's complicated to obtain. And the fact that we observed more patients with longer spinal lordosis, like this patient where lordosis was too long. And in this case, we don't often do something for this lower part, for the thoracolumbar junction. We mostly flatten this area, but if we flatten it, the patient is backward tilted and he needs to flex at the top. In the PGK group, what we saw is that we didn't observe any correction of thoracic kyphosis. Most of the time, we had a global lordosis increase, meaning that the thoracolumbar junction was too much extended. And because the inflection point was located more proximally, like in this patient, the patient had to flex. You see here again, lordosis is long. All this area is lordotic. Usually it should be straight. So the patient needs to flex somewhere and he or she flexes at the top. The other problems when we don't address correctly sagittal alignments are pseudarthrosis, because if the patient has the need to collapse to the front, we'll have malunion here, but we can have the same in the lumbar or thoracolumbar junction. And the second problem is the aging of the unfused spine. This is the work that we did during my PhD, looking at the factors that were related to rehydration of the discs after fusion. When you leave a lower lumbar area unfused, this area will be overloaded. So you have to fuse it in the proper way. We know, and we showed it in this PhD work, that the frontal balance was very important. We have to get as much as possible a straight lumbar area when we correct AIS. But in the sagittal plane, we saw also that there were factors that were very important, like spinopelvic alignments. We saw that patients with a low PI were more favorable to disc rehydration, which is good news for patients with small PIs. We don't need to correct too much. Patients with high PI had more junctional stress, thoracolumbar junction, L5S1. So for these patients, we have to be very challenging in restoring sagittal alignments. And ideal rebalancing of the frontal plane and the sagittal plane were both independently able to create early degenerative disease at the adjacent segment. So we have to address both of these problems. So our conclusion was that when PI was high, which is quite often the case in AIS patients, the thoracolumbar junction had to be stabilized or at least corrected. And in case of fusion below L2, we had to really perfectly restore the upper arc of lumbar lordosis, meaning make it straight. Don't give any lordosis like we saw in this patient here, where lordosis was too much and the patient couldn't readapt in those discs here. So now that we discussed about the problems that we have to address, the question is, what are these different sagittal patterns that AIS can produce, and what can we do to make a better 3D correction? We discussed about the fact that there were reciprocal relationships between the different areas of the spine, the cervical, the thoracic, the lumbar, and each junctional zone is crucial. Two junctional zones are very crucial for idiopathic scoliosis when we correct them. First, it's the thoracolumbar junction, the lower parts, and second, it's the cervicothoracic junction. But there is another important point, it's the behavior of the lumbopelvic area. Lumbar lordosis is bounded by the orientation of a S1 plateau, which is the sacral slope, which is under the dependence of pelvic incidence, and the position of the inflection point where our patient is going to start his kyphosis. So as we saw in the previous patient, kyphosis was very high and the patient had this inflection point quite high. So lordosis was long and distributed between a lot of segments. But some patients will have a longer kyphosis and the inflection point will be lower. Second, the lower arc of lordosis is equal to SS, which is approximately 2/3 of LL. Upper arc of LL is equal to lower arc of TK. So we can make some equations, and I can send you an article that I just published in the French orthopedic journal, where I summarize all these different equations that give you the normal alignment of the spine. And this will help gradually to know how to correct the area where we are going to place the correction and the fusion, and how we should bend these rods. So you see here, lordosis distribution is ideally sacral slope, plus minus 20 to 25 degrees. This is a fixed angle. The inflection point is here. So if we adapt it to our patient that we saw who made a PGK, we have to reduce this arc of lordosis in order to make a more appropriate adaptation and position of the inflection point. So in AIS patients, what we see is that in the structural zone, and here we have a double thoracic curve, scoliosis will produce hyperextension between vertebrae. This area is normally kyphotic. It becomes lordotic. In the lumbar spine, here we don't have any structural deformity. So the patient is in accordance with his alignment with PI that is approximately about 55 or 60 degrees, and a sacral slope that is adapted with a normal anteversion here. So the patient has only this flat back that we have to address by correcting thoracic kyphosis. This is the classification that we developed. This classification was meant to describe all the scenarios that scoliosis is creating in any kind of lanky type scoliosis. And we found 4 subtypes found type 1 patients that kept a normal kyphosis, patients who developed hypokyphosis, like this previous case, patients who had hypokyphosis, but they had also a thoracolumbar kyphosis here, T10L2 angle that is positive, with an angle that is more than 10 degrees. And also patients like the one who developed PGK with a long lordosis in the lumbar and the lower arc of thoracic area, and then a proximal kyphosis in order to try to restore the C7 plumb line and not to stay too much backward tilted. If we look at the Lenke types distribution according to the sagittal patterns, we see that in thoracic deformities, we have less than 40% of patients that are normal. Most of them have a pathological pattern because it affects the center of the spine. It automatically has an impact on the lower, but especially on the upper arc. So if you have an apex that is around T8, T9, you will have a flat back, and you will either create this hypokyphosis, or you will create a lordosis in this area, and the patient has to readapt by kyphosis in this region. If we look at patients with thoracolumbar or lumbar scoliosis, and with a very mild thoracic deformity, those are most of them normal. You see that more than 60% of these patients keep a normal kyphotic spine, and some of them can develop some junctional problems. If you have a strong rotation in this area, automatically your patient will lose this straight area and will kyphose in this area. So this subtype is also observed in the thoracolumbar deformities. How have I included sagittal classification in my practice? First, I try to have the same way of thinking as the Lenke classification, looking at thoracic kyphosis, thoracolumbar junction, and cervical alignments. I could define if the patient had a structural or compensatory deformity. And depending on that, I could determine which pattern it was. Then I'm using it in conjunction with the Lenke classification to guide my 3D correction in order to decide where to act and how to shape the rod. So now we're going to see the targets of correction and the possible strategies and discuss about preoperative simulation. These are the guidelines given by the classification, and we are working on the next publication to show the results after 3 years of pre-bended rods use. You see that here we have patients who have a normal shape. Here we want to keep that shape, so the correction of scoliosis will act only on the frontal plane. We'll see some cases. When they have a flat back, we want to bring backwards the spine. So we are going to act with posterolateral translation. For this, I'm often using sublaminar bands. And in this case, where we have a long lordosis and this proximal thoracic kyphosis, you see that the shape is completely changed with a thoracic kyphosis that is corrected in the lowest part around the thoracolumbar junction between T10 and L2. And the only area where the shape is back to the spine is the first lumbar vertebrae that is connected. So here's a case of a patient with type 1. You see that this patient has a thoracic deformity, which is a Lenke 1A. This patient was candidate to fusion of this curve, and you see that the last touch vertebrae was T12. I decided to go to L1 because most of the time we want to have control of this area on the sagittal plane. And you see that the shape of this patient was slightly flat here, but we didn't change anything to this flat area. we just asked for a rod that was exactly the same shape with an overcorrection on this side, on the concave side, in order to translate with the bends. And you see here the screws on the top and the bottom. And you see the sublaminar bands here in order to bring the spine. Nowadays, I use more screws in this area in order to have a better translation, especially when there is a large rib hump. And if there is additional rib hump to correct, because kyphosis maintenance doesn't give you enough pushing ability, then you should consider thoracoplasty. Here we have a lanky 2A. This is a patient with a true flat back. Here, the apex of the deformity is around T10, T11. And you see that the flat back is really acting in this area. We have some kyphosis developed here, and we have a patient with a PI that is large. You see that the lordosis is quite well distributed. So in this patient, we keep the shape here. You see that we just place the rod at the contact of the very end of the construct, and then we start to reshape the lordosis, the kyphosis, sorry. And again, we use sublaminar bands. In this patient, we added some Smith-Peterson osteotomies in order to bring the spine, because when you see the ribs, you see that the structurality of the deformity was important. And this helped us to correct by posterolateral translation again. You can see that the shape of the lumbar spine is exactly the same. And you see that the orientation of the sacrum has been maintained very similarly. So we really act on the structural deformity on the sagittal plane, and we don't touch at the length and the distribution of lordosis. In this case, we have a patient who developed a flat back, but because of this double curve, it's a 3C, the thoracic deformity created a flat back, created this lordosis. But at the junctional zone, because it's an area where you have opposite rotations, we have like a dislocation, and that's why this patient enters in a type 2B in our classification. So in this patient, what we want is to change the shape of this area by pushing upwards the lordosis. You see that the patient has a PI that is about 45, 50 degrees, but sacral slope is very low. You see that the sacrum is almost horizontal here, and that the sacrum is very vertical. By giving more lordosis, the patient is then able to have the proper orientation of the sacrum, which is more relaxing for the patient. It's not retroversion. And by creating this upper lumbar area lordosis, we can make it a little bit longer, and the distribution is much better. And then we act again on this area, especially at the apex of the deformity, in order to create lordosis, to create kyphosis, sorry. Again, sublaminar bands to bring the spine on the concave side, and with an overbended rod on the concave side. Here we have a mild lanky 5C. This patient has a lumbar deformity with a hump that was quite huge and pain in the back. The correction in the frontal plane was quite easy, but the question was how to bend the rod in this patient. We just decided to bend it straight. You see that we prolonged a little bit the lumbar lordosis, and we gave a beginning of thoracic kyphosis here in order to avoid that the lordosis is too long, and that the patient requires to adapt and to create a PGK. Here we can do a pure derotation maneuver because it's kyphotic. So if we push on the convex side, so we work from the convexity with an all screw construct, we can easily recreate lordosis here. and we can easily fix the patient in the right position. The most complicated patients for me are the lanky type, the Abelin type 3, because as you see again, these patients have a long lordosis. So the challenge is really to bring this area of the spine backwards. It's not very usual that we do Smith-Peterson and we try to create kyphosis in an area that is close to the lumbar spine, but in this patient, it's absolutely necessary. The apex here is between T8 and T6 and T8. And you see that the correction would be usually to give kyphosis in this area. But in reality, there is still a lot of structurality of the deformity in the lower spine. And we have to do a longer construct. If you do only a short fusion like a T4, T12, or even T2, T12, you will not address the repositioning of this area. If you do too short, you may end with a kyphosis or with some troubles in the thoracolumbar junction. How do I analyze this? Usually I look to these different parameters. As I told you, I look at the apex on the frontal plane and I see what it produces in the sagittal plane. I look at the position of the inflection points, the lordotic vertebrae with the opening of the discs, and then the kyphotic vertebrae. And I know exactly where is this inflection points. Plus, I measure T4, T12 thoracic kyphosis and the thoracolumbar junction angle, which is T10L2. And using this, I can determine easily the type of Abelin classification patient. So here's a resume of the practical use of this classification. First, I look at the sagittal parameters, pelvic incidence, pelvic tilt, sacral slope give me the Roussouly type. Then I look at the thoracolumbar junction here. I see if it's straight, if it's lordotic, or if it's kyphotic. If it's lordotic, then it means it's a type 3 here. If it's straight, it can be either a normal kyphotic, so it's a type 1, or it may be a patient with a flat back, so it would be a type 2A. If the thoracolumbar junction is kyphotic, it means that the patient has adapted with a compensation of the flat back, and then we enter in the 2B patients. Nowadays, I systematically use a computerized simulation of sagittal correction. So I know what kind of patients it is. I know where I have to act. Type 1, I maintain. So I just want a rod that is the same as the shape of the patient. Type 2, I need to correct thoracic kyphosis. So I start to work around T8, T9. And type 3 patients, I have to work on the thoracolumbar junction. And depending on that, I will add my different corrections on the simulator, and I will gradually determine what is the ideal shape of the patient. This will automatically be sent to the manufacturer, and this unit rod will be sent in order to have it for my surgery the day of the fusion. Here you have an example. We have a patient with a quite mild deformity on the sagittal plane, but in reality, she was really ugly with a big rib hump and especially a very lordotic thoracic area. You see when we do the reconstruction that we have a patient with almost no kyphosis, only lordosis in all this area. So we would like to bring the spine backwards. And doing that, we want to bring the spine in the middle. So for this patient, PI was high, 68 degrees. So we had to maintain a lordosis that was that shape at the beginning. So if we look at the area until L4, we will maintain it. We see that the sacral slope was adequate. You see 59 degrees, which is correct. But the main problem is thoracic kyphosis that is very low, it's lordotic. So we have to reshape it and to replace the transition, the inflection point in this area. So here what we did is that our goal was to create spaces like we do with Smith-Peterson osteotomies to get correction at different levels of this very lordotic area in order to bring segment by segment to the back and to get the correction of this type 3 in order to bring the patient to the rod. And we kept a straight thoracolumbar junction. And because the patient had a high PI, we could maintain a lordosis that was quite sharp because it's a Roussouly type 4. Here you have the patient with the final results, and you see how the spine was brought and how the thoracic kyphosis is now much better distributed. And the transition is between T12 and L1, which is the adequate situation. We see also that the sacral slope has not been modified, and we see that all the other parameters are in green. Lumbar lordosis, that is still high, and thoracic kyphosis, that is about 34 degrees, which is in the normal values. If we look a little bit to the first 100 patients that I did and were corrected with pre-banded rods, we see that from the pre-op values of TK that are very widely, largely distributed, the planification in blue is quite the same range as the post-op values. So we were able to get this correction. And interestingly, because during the simulation, we are not always sure to get the ideal situation, we had a quite large distribution of the values. And you see that here, most of the values were very close to 30 degrees, which is meant to be a normal kyphosis. So this is really interesting. And the other interesting thing is that the mean error in thoracic kyphosis was about 5 degrees, which is not bad at all. And for the lumbar lordosis, it was much better, 2 degrees of error, which is quite interesting if we think about the fact that we have to keep an ideal shape of the lumbosacral area. Sorry. So these guidelines given by the new Sagital classification were accurate to guide the strategy of surgical correction. We knew where to place exactly the different levels of correction. All the patients that had these pre-banded rods achieved and maintained a satisfactory sagittal alignment postoperatively. And we had only for now among 150 patients, we had only one radiological PGK, and none of these patients was reoperated for a PGK. And if you think about the 300 patients that we looked at with a 15% of PGK, this is really a very interesting finding. And I hope that you will soon read this paper that we are going to publish in the next weeks, hopefully. So the use of these patient-specific pre-contoured rods allows an adequate and predictive correction of the profile. And I think this will really help us to reduce the complications for our patients and to get a much better correction. So the conclusion is that if the patient is well balanced, we have to maintain his shape. If it's adequate, we just need to do a pure translation and to do as much possible coronal correction without flattening of the spine. So translation is better obtained with sublaminar bands and by reducing the number of screws at the apex of the deformity. And if the patient is imbalanced, then we have to carefully adapt to the sagittal shape. We have to look first at the length and repartition of lordosis. We have to analyze the thoracolumbar junction. And then we have to select the correct maneuver, either posterolateral translation, if we want to recreate thoracic kyphosis, or derotation if it's like a thoracolumbar kyphosis, or a lack of kyphosis in the lower arc of thoracic area. So, Luis, we have some case discussions now. I don't know if you want to share first your cases, or if there are any questions from the audience.
Not so far, but actually I'd like to remind the audience that if we have any questions, you may type them on the chat box or the Q&A. Sorry, go ahead, Dr. Luis.
Kariman, I think you may start first, and then
Okay.
if we have time, I have one with a complication, and then I need you to analyze from this point of view, in spite of we not having the AOS and the KOPS using it regularly. Okay.
Okay. Okay. So this is the first case, and I shared with you some predetermined questions if you want to answer online. This patient has a right thoracic AIS deformity. We have clinically thoracic hump and lumbar hump. The thoracic is much bigger. The patient is complaining about cervical and lumbar pain. The lumbar pain is located on the convex side, and the cervical pain is more about fatigue. And this patient is at RESER 4+, meaning that the RESER sign is almost reaching the end of maturation. And if we look also at the humerus, looking at what has been showed by Shop, we see that this cartilage is almost close to 2. So the first question here is what kind of deformity it is on the frontal and on the sagittal the sagittal aspect of the deformity. Would you on this be able to say if you would like to observe the patient, if you would like to try any conservative treatment, or would you advise a surgery, and for what reasons?
Do you want me to, sorry, do you want me to launch the poll here? That way everybody can vote?
Yeah, maybe. Yeah, for the
Okay.
first question.
There we go. So question is on the air. Everybody can vote.
So what would be your attitude on this patient? Would you advise waiting, bracing, doing a surgery? And if you do a surgery, would you advise a short surgery, or would you advise a longer surgery?
How bad is the lumbar hump?
The lumbar hump is about 10 millimeters. So it's a mild one, and it's quite reducible when you push on it and when you ask the patient to try to correct the small coronal imbalance that she has. There is some flexibility.
All right, so let's go here. So here are the results. So obviously there is a surgeon community.
Yeah, I think so. But I think also that our rehab doctors would advise some surgery, because she was sent by the rehab section of our hospital, and she was fed up with bracing and it didn't work. But interestingly, we see that a lot of people would advise to fuse both curves, but there is some of the audience that is thinking about doing a selective surgery. So this is really interesting. What's your idea about this case, Luis? What would you do?
I think you need to go higher, not T4. And I think you have to go down to, depending on the flexibility, sometimes we are really doing some different movements in the lumbar spine, stop shorter than Cobb for this I wouldn't consider three structural curves, but maybe a C modifier in the lumbar. Then
Okay.
I would try 2 or 3. Depends on the how it responds during surgery.
Okay.
But I think I go to T2.
Okay. So if I show you, why doesn't, oh yeah. Okay. If I show you these bending films and the traction, would it change something for you on the decision?
Yeah, I think I go to 3 to T. Well, good. This is laying down in the middle.
This one is a suspension that we do standing.
Okay, I would
But
stop at L3. Yeah.
F3 here. Okay,
yes.
Good. So what we see is, I think you agree that we have here a thoracic upper curve. Then we have a thoracic lower curve, which is probably the main one. And we have rotation that is maintained on traction and on the bending films. So this is also clinically structural. We see it with the rib hump, and radiologically structural. So I agree, I would consider going to the lumbar spine, at least the beginning of it. So maybe we can launch the second question on this.
Sure.
What would be your Lenke classification? It's always interesting to see how people are classifying this kind of patients. Do you think it's 2A? 2A means double thoracic without a lumbar curve or structurality. Lenke 2C, meaning that we have a double with a structural mild curve here. 3C means that we have a thoracic and lumbar curve, and Lenke 1C means that it's only a main thoracic with this deviation to the central sacral vertical line.
We're gonna give a few more minutes for people to
Yeah.
vote. While people is voting, can I give you a question that came into my phone here for you,
Yeah.
Dr. Kariman?
Of course.
So Dr. Defino is asking if there is a place for anterior correction to improve thoracic kyphosis.
This has been debated, I think, 10 years ago. We showed that, of course, the big question was the length of the anterior wall. So when we go to the front, what we do is that we remove discs to get more ability to flex, to bend this area. But in reality, the true correction has to be done on the posterior side. Scoliosis is not an overgrowth of the anterior wall. It's truly a shortening of the posterior wall. And this has been recently showed also by the team of Utrecht, that the discs are overhydrated in the thoracic area. They are very high. But in reality, for me, what happens is that it's too stiff in the back. So from the anterior, you will not get a lot of correction. But if you do removal of the ligamentum flavum, if you remove the joints on both sides, you will get some possibility to reopen these spaces, while from the front, you will only get more flattening, but I think you will not get enough thoracic restoration.
Okay, thank you. So the answers are here, and there is another question for you, Dr. Luis, when you consider it on time. It's in Q&A.
Okay.
So here, if we look at your answers, I would agree for a Lenke 2C, limit to Lenke 2B, but I think this central sacral vertical line is not crossing this area. So for me, it's a true double thoracic curve. And that's why I agree with Luis saying that we have to fuse this area. Otherwise, if we fuse only the main thoracic, we will get imbalance of the shoulders. You see this here with this curve that is still there. Sometimes also it is easy to show to the youngest ones that if you look at the structurality between the ribs, here you have big spaces and here you have small spaces. This is another way of looking at the structurality of this curve. So that's why I would include this curve in the fusion and include all this one in the fusion and the beginning of this one, considering the Lenki rules. Luis?
Yes, I fully agree with you. I think considering the shoulder level, the T1 tilt and the ribs, I think the proximal is structural really. And probably the best way of analyzing the flexibility extraction in the upper thoracic, not bending because it doesn't work. And I fully agree with your considerations.
Thank you. So you had a question, I think?
Me? No.
Yeah,
No?
there are 2 questions in the Q&A.
Yeah.
Okay.
Okay. I think this is Olavo Letaif. How did 3D classification will impact our daily practice and the current classifications, Lenki and Abelin? Considering the most hypokyphotic spines are truly hypokyphotic.
Even more.
So,
Yeah.
Okay.
Okay. So sorry, I go back to the previous one. If we look at this patient and if we try to apply the principles, we see that if we follow Lenki, we are going to fuse these 2 curves at least and start to fuse the beginning of this one. So I would probably consider doing T2, L2 in this patient at least. And now if we look at the sagittal plane, I have some problems with this. The question now is how do you perceive this sagittal alignment? So I'm going to try to answer to your question, Olafo, by looking at this picture and asking you what you think about this patient on the sagittal view. So maybe, Boyce, if you can show the answers to the 3rd question.
Okay. Third question, it's on the air.
Yeah.
So
the question is on the sagittal plane. Do you consider that this patient has a normal alignment? Do you think that this patient is hypokyphotic? Do you think that this patient is hyperlordotic? Do you think this patient has thoracolumbar lordosis, hyperlordosis, and a cervicothoracic kyphosis, like the case that developed PJK in the beginning of my talk?
So everybody's in agreement, and
Okay.
let's end the polling here.
Yeah.
There you go.
All right.
Hypokyphotic.
Thanks. Hypokyphotic. Okay, I think everybody is okay. So I fully agree. This patient has a flat back here. So if we add the fact that this patient, has this triple curve that we have to fuse this area, and with that we have a flat back. If we add these 2 informations, we know where we are going to extend the fusion by the Lenki classification. And knowing where we are going to start our construct here at L2 at least, we know how we are going to reshape this patient. If we look at the shape of the rod, you see that the beginning is just ending what happens at L2, L1. And the apical structural area on the sagittal plane is this area. So we know that we need to restore kyphosis in order to relax this cervical spine and to allow the patient to flex a little bit T1, C7, and to get more kyphosis. So the information that we have is about where we're going to act and where is the most rigid area. And we know how to place our instrumentation. As I told you, in this case, I'm not going to do DVR, because if I do DVR, by derotating, I will increase lordosis. So I will increase this long lordosis here, and my patient is going to develop a PJK. So what I need to do is to bring backwards the spine. And for that, I will first put the screws in order to get a coronal translation. And second, with the sublaminar bands, with the large openings with the Smith-Peterson, I will be able to bring backwards the spine in order to place these vertebrae in a kyphotic manner. So this is how I use it every day.
Kariman,
Yes.
Your pre-bent rods are both cobalt chrome, or are you using some other stiffer rods?
For the moment, this patient had 5.5 rods. This is a patient that I bended myself. You can see it because it's not beautifully bended. But most of the time now I use titanium diameter 6 pre-bended rods because it's strong enough not to lose too much, and I overbend the concave rod. I do my simulation for the convex side because I know it's going to fit exactly on the hump, and I'm going to push to do derotation. And then on the concave side, I overbend about 5 to 6 degrees around the apex. So it means 2 degrees per levels of maximum of correction to allow the tension of the bends, because I know I'm going to lose a little bit. When I started my experience, I started with cobalt chrome rods with 5.5. But the use of cobalt chrome in young patients for me was a little bit difficult to consider for 2 reasons. First, because I read some papers about the cancerogenic role of cobalt chrome, potential role. So there are some advices by the World Health Organization not to use this kind of implants. And second, because titanium has shown to be better against infection. And that's the reason why I decided to switch to titanium 6.
Okay, thanks.
So, Dr. Luis and Dr. Kariman, we have someone from the audience that may have a question. Can I have it now, or do you rather want to finish your case?
Oh, we can have the question if you want. Yes, of course.
Okay. So, Dr. Ferreira, if you want to turn your mic on and make your question. Probably he raised his hands by mistake. Okay, you can move on.
Okay. So, Luis, do you want to share your case?
You have one more? Just go, because I think we let's.
Yep.
Yeah. Well, okay. Let's do it.
As you want.
No, do this one first, and if we have time, I present mine.
Okay. So this is a second case. This patient is a severe thoracic right thoracic deformity. On the same way that we discussed, you see that this patient has one main thoracic with an apex around T8, T9. Here we have no lumbar curve. We see that the CSVL is touching L1, L2 disc, but it looks like a 1A. I don't know what you think about it.
Yes, I think so, 1A, but it's slightly different because it's a longer curve, but I agree, yeah. It's 1A.
Yeah. What is really strange is that when you see the traction film, the suspension, you see the rotation that appears in the lumbar spine. So there is something with this curve that the King classification was more addressing than the Lenke classification. Right. Because if we consider this one, we would do something maybe short, saying that more we correct it and the more the patient is straight. But here we see that something can happen in the lumbar spine. So for this patient, I personally didn't want to do something short, and I really considered working on the stable vertebrae like the King classification showed us to work on. Would you comment on what you would do in this patient and regarding also the sagittal profile?
Yes, I think as the apex is a little bit lower and the curve is slightly longer, like COB is L2, I think. No, this is 12 or?
Well, this is L1 here.
Okay, okay.
And the most tilted is L1, but I agree that this one is the neutral one. Yeah.
Right. Then I agree that maybe she's flat. I think she's seems to be flat from.
Yeah, almost lordotic here. Yeah.
I think you need to go longer, as you mentioned. In the band, in traction, you see that L2 is not okay. This is T12, I think. L1, L2, L3.
This is 2 and this is 3 here. 3? Yeah. Yeah.
Well, I would say at least 2. You have to go down. I think wouldn't go shorter than that. And I would go actually to T3 or T2 to get better correction of the hypokyphosis. But I have to recheck if it's going to be okay. And L2 is going to become neutral because sometimes it doesn't. I think then the patient is going to decompensate to the right.
Yeah. So if we look at the sagittal plane, we see here that she has a high PI. I think I have the measures after. So she is meant to have this sacral slope. We see that pelvic tilt here is about 15 degrees, which is quite normal for her. So the beginning of her lumbar spine is correct. But the problem is that if we look at the inflection point, it's almost here. So the patient has a too long lordosis and there is almost no kyphosis here. So if we do a fusion and we do derotation maneuvers, we try to correct this too much, we can end with a very flat back. And in 100% of the cases, we have a PJK here. So for this patient, the challenge is really to restore kyphosis in the lower arc here. So now if we look at the simulation of this patient, you see that the apex of the deformity in the sagittal plane is almost this disc. It was quite open. If we look at this area, it's around this junctional area. And it's interesting because if we look at this picture, we say it's a 1A. And if we look at the suspension, we see that there is a curve here that seems to be a bit structural. So because of the importance of the main, we don't see all the structurality. Clinically, we can see probably something like a hump. And radiographically, we see that the structurality is in the sagittal plane. So here the patient has a very high PI, 72 degrees, which is a lot. Most of the time, these patients have a spondylolisthesis and not a scoliosis. We see that sacral slope is in the normal range, 62. Pelvic tilt is about 10 degrees, which is also normal. We see that the patient is, even if she's very lordotic, she's still a little bit backward, forward tilted. She is a little bit unbalanced. This software shows us that she's a Roussouly type 4 because of the shape of her lumbar area. And if we follow all the green vertebrae, we see that lordosis is very long and that the area of kyphosis is short. It's about 36 degrees in this area, which means it's not bad. So if we keep a beginning of this shape and we prolong it, we might end with a proper correction. I also measured T4, T12 angle, showing that she's flat in this area. So if we look at this classification, she is that kind of patient. So we have to correct this area of the deformity. And you see where the correction was on the sagittal plane. It was on this area. This is something that you can easily do even with prints of your sagittal plane. That's what we did before having any softwares for this kind of patients. It's easy to make your cuts and to put your patient here to make your own idea on how to place the correction and how much to do. You see that the patient here has about 2 degrees of correction, 3 degrees, 4 degrees. The correction is mainly in this area here, so where it shouldn't be so lordotic. And you see that we also redistribute lordosis, because you see that these discs are completely collapsed here. We need to recreate lordosis to redistribute it. So what is corrected on one side is given back on the reciprocal angle. And doing this, we see that if C7 plumb line is in adequacy. So we add the correction in the structural area. We give back what we can in the lumbar lordosis area, and we see if the construct looks nice. And this is the least correction that we can do, because if you do too much, of course, it will be too challenging, and that's how I address this patient. Do you have any comments, Luis? Would you do it in another way?
I would try. And in this situation, did you stop it at L2, I think?
Yes, I stopped in L2 because I wanted to manage this disc that was completely opened here. And the second reason was what you said, the fact that we had this like a structural curve. And I wanted to start to stabilize it, not to, if I did too short, I think probably I would end with a curve that wouldn't automatically correct. We can see it also on the bending films here. She has a true structural curve in the lumbar area.
I agree with your comments, absolutely, yes. I think we have one question from Ricardo Mosquera. Yeah. That maybe later. Thanks for lecture. What about adding on phenomenon in this kind of curve in your experience?
Oh, very, very nice question. This is hopefully the next step of my work and the next publication, because I have one theory about this. My theory is that adding on phenomenon most of the time is the way for a patient to readapt. Meaning that if we look at this patient, you see the final shape here. And you see that there was something here. And you see that initially she was not perfect. I was a little bit afraid of what would happen. And I needed to L2, like you said, Luis. Yeah. And thanks to God, with time, you see, she readapted. So I'm happy with her, but it could have been a problem. If you end with a patient like this, or even with this, but your sagittal plane is not the adequate one, what the patient is going to do is that he's going to rotate the vertebra at the junction here, because he's going to readapt to what you did. What I mean is, if you maintain this shape, the patient will have PJK. But if you do too much, if you forget that this patient needs a lot of lordosis, you will have a very straight spine here, and the patient, requires to have lordosis. So to get a little bit more lordosis here, the best way to get lordosis is to create scoliosis. So you will turn the last vertebra and you will create the adding on. So for me, this is really the mechanism of adding on. But this has to be proven, and the problem is that I don't have enough adding ons. I mean, you can't prove this with a case report. So I need volume for this, and it would be interesting to have a multi-center database to prove it.
Just turned perfectly. That's the point. Orthopedic surgeons that do spine, they don't need to be too anxious when you see that slight decompensation. They need to take your time and see how the
evolution,
the curve behaves on the time.
Yeah, exactly. We have to take time to see, because our patients are normally scoliotic, and we bring them to an abnormality, which is a straight spine. And even the sagittal plane for them is completely new, because as I told you, my thought is that in these patients, the structurality is due to the fact that they have very fibrous muscles or capsules or ligamentum flavum due to scoliosis. And because we destabilize them, we bring back the spine here, the way they are placing their skull and their center of balance is very fragile for them at the beginning, and they might not adapt initially. Here we have a very nice cervical shape, but in the previous one, I think we saw that, you see the cervical spine is a bit tired. It will take at least 1 or 2 years to readapt and to place in an adequate way. And in the frontal plane, it's the same. Sometimes you have a small curve that remains, but with time, the patient relaxes, replaces the pelvis. You see here, the sacrum is more tilted and more adapted. And this will help the patient to end the final correction here.
Kariman, I have a question. Have you been able to correlate the degenerative cervical disease according to hypokyphotic thoracic spine, or only discomfort and pain?
Only discomfort and pain for the moment, because I don't do systematic MRIs. I'm screening literature for now more than 1 year, because for the last SRS, physically given SRS in Montreal, there was a team from Japan who looked at MRIs of patients who were 10 years after an AIS fusion, and they looked at hydration and signs of degeneration. And interestingly, they showed there was a correlation between hypokyphosis and degenerative evolution in the cervical spine, especially around C3, C4, and C4, C5. But for the moment, the publication is not on PubMed.
Let's see if we have some more questions.
Yeah, there is the Dr. Luis Eduardo.
Yeah.
Dr. Olavo has a question. So, Dr. Olavo, if you can turn your mic in and you can ask live.
Hello, thanks. Congratulations, Kariman, on your last case and the long-term evolution. What I would like to ask you is about the bending films. I see you use bending films a lot. There are some surgeons that are no longer using bending films. And considering this last case, I would probably have chosen L3 as the end vertebra. Considering that the disc space between L2 and L3, the end plates, they don't get parallel on the bending films. They still have a wedging.
Yeah.
Do you take this into account? How are you using bending films? Are you taking the most advantage of these films?
Yeah, so bending film for me are very crucial, because I still believe in the principles that I've been taught by Jean Dubousset about the parallelism of the end plates and about how the disc is behaving. You know, he's talking a lot about soft tissues, and you see that this disc is not opening, as you said, so well. So I agree that looking at this, you would probably consider to go to L3 to really make sure that the patient is going to realign. Bending films are essential, but often I use bending films and I use the suspension. I know it's a lot of X-rays, but for me, this surgery should be the only one. There shouldn't be a second act or a third act for the patient. So it's better to have 1 or 2 more X-rays and to explain to the patient why we need all these informations, rather than having a lot of X-rays when they do their complication, their PGK, when you have to do revision surgery. So these bending films are crucial. And if I would advise something now, when I have severe cases like this, the suspension is no more standing, but it's supine, and I do it myself. I go to the departments and I do my best to make sure that the patient is relaxed and that I can use maximum of his flexibility. And I also add in those cases where you have a rigid area here, films on the sagittal plane, bending, anterior bending, and this helps me to understand how is the flexibility of this area. I don't think I have a case shown here, but this film is also very interesting to know what is the flexibility in flexion of the thoracolumbar junction.
Great.
Okay. Karima, I think we're about running out of time. I think
Okay.
was a wonderful talk. I think sharing your experience really clear up a lot of doubts. I just
Thank you very much.
One last question. Considering that most of the services in Latin America, they don't have EOS, do you think just regular X-rays may eventually solve this problem? And how can we fit this panoramic X-rays to the CHEOPS?
Yeah. Well, I have the answer because I now with COVID it's a problem, but usually I go once a year to my friends in Armenia. It's in Central Asia area near Iran and Turkey. And it was a department that had only small cassettes, not even the 30-90 centimeters cassettes. And they could only do images like you see the bending ones. So we had either thoracic or the lumbar area. So I had always these kind of pictures, half of it, the same here. And what we did is, because these long cassettes were quite expensive for their analogical system, if you have still the chance to have numerical X-rays, if it's computerized cassettes, then there is one possibility to merge them, to have a first picture and just to slide it in order to make the exact fitting with the ribs, which is often enough. Even though the pictures were not made in the same time, the patient has to stand, and I think an adolescent can stand in the same way for a couple of minutes. And doing this, we could obtain these long films, even in the sagittal plane, and we could still use it to understand a little bit about the patients and to make our thoughts about how we are going to correct the patients. So I really think that there are some solutions that can help, even though you don't have the EOS system.
Okay. Well, I have to thank Boris and Medtronic, and especially
thank you so much. Yeah.
For expending your time when you were at home. I think it was a great
With pleasure.
Opportunity to share your knowledge. And I think you're always very appropriate when you consider all the knowledge you've been able to assimilate during all this year with this French school. That's marvelous, really. I think you have a very different way of understanding and interpreting the deformity of the spine. Thank you very much indeed.
Thank you so much, Luis. It's always a pleasure to discuss with you. And I think we share very similar thoughts, and hopefully we are transmitting what our peers have shown us. And I think now we have a lot of knowledge. We just have to place it in order and to know what is really crucial. And I thank you for this session, because this webinar, because we could really emphasize the importance of sagittal alignment, not only pelvic incidence and angles, but really understand where we have to correct and what are the consequences of our acts on the patient. And if anyone needs any information about the data I was talking about, please don't hesitate. I can share with you the references. I can also share with you the papers I have. I will be very pleased to discuss with you through chat or email. So I think best way is probably to send an email to Boris, if you agree, Boris. So
Yes, of course.
you will be the intermediate.
No, thank you so much. I think one of the positive things of this pandemic, we can take many, but this is one of it. We get access to you and your experience, and put together to your friend Luis, that was an outstanding moderator, and have this session that I think was a kickoff, because it was so many questions that maybe sometime later next year we can do something else. But for today, thank you very much to all of you for
Thank you so much.
being here. Thank you very much, Dr. Kariman, for your generosity. Thank you, Dr. Luis, and good afternoon all. Merry Christmas.
Thank you. For you all.
All right. Take care
Bye-bye.
of you all.
You too.
Bye-bye.
Bye-bye.
Bye.
Merci beaucoup.
Je vous en prie, merci de votre constante gentillesse et, et votre persévérance. Je suis désolée.
Non, c'est moi.
Je suis un peu croulée sous le travail. Et puis, je vous ai fait attendre. En fait, on a eu une réunion de crise pour le Covid à cause de la reprise d'activité au mois de janvier. Et j'ai eu beau leur expliquer qu'il fallait que j'y aille. C'était un peu compliqué.
Non, mais vous inquiétez pas. Et merci à vous. Je crois que c'était vraiment un excellent webinaire. Et ça, c'est effectivement une superbe opportunité aussi pour les gens en Amérique latine d'avoir ces présentations de votre part.
C'est super.
Vraiment,
oui.
Très, très bien. Je vous remercie.
Merci beaucoup.
Je vous laisse vite retourner à votre famille.
Je vais retourner à la petite famille. Voilà, c'est ça.
Bien. Oui, à votre deuxième, voire troisième journée.
C'est ça. Au revoir.
À bientôt. Merci.